She's senior palliative care physician. She did her MBBS from Kogulam Medical College, Trivandrum, and she did her certificate course in pain and palliative medicine from Pallium, India. She's her main interest in community home-based care and pediatric palliative care. Now she is in charge of our pediatric palliative care department. So she has around 2 years of experience in palliative care. So she is a well-versed person in this field. Ma'am, welcome and over to you.
Thank you so much. So today's session, as Sister Shiva said, it's a continuation of GI part 1. I hope most of you are in a background somewhat related to palliative care. So I hope this session will be more useful in your day-to-day activities where you're taking care of patients. Today we will be seeing the second part of GI, mainly focusing on intestinal obstruction. This is a very common progressive symptom that you see in a patient with gastrointestinal diseases, mainly in a progressing condition where the patient is found to have, in an advanced stage, you could get to see the patient with intestinal obstruction. Today, what we are going to see is how do we diagnose this, manage this, and all those things will be based on a palliative care perspective. It's not similar to something which you see in a regular like surgical department, how you do the intestinal obstruction management. But here it is little bit different. From a palliative care perspective, we'll see how we can take care of a patient with intestinal obstruction. Okay. So today we'll see the classification of intestinal obstruction, the symptoms of intestinal obstruction, and how do we diagnose this, the management of malignant bowel obstruction, and the treatment in intestinal obstruction from a palliative care perspective. So before we start, we'll go through a case history so that it will be more easier for you to understand the topic in depth. So here we have a patient called Mary. She is 62 years old and is diagnosed with stage 4 gastric adenocarcinoma. And she's having metastasis to peritoneum and anterior abdominal wall. She had a palliative distal gastrectomy followed by chemotherapy. Unfortunately, a repeat CT scan showed after 2 cycles of chemotherapy, the repeat CT showed there is progression of the disease into peritoneum and abdominal wall. Very commonly, you can see people in this stage, in particularly presenting to you with sometimes vomiting or abdominal pain. Okay, so let's move on and understand what intestinal obstruction is, and then come back to the case to understand it better. So intestinal obstruction means, what does it mean? It is the restriction of normal passage of intestinal contents. So there is some obstruction somewhere. Okay, and now the patient is presenting with some symptoms. There is 2 ways we classify intestinal obstruction. One is non-mechanical and another one is mechanical. In non-mechanical, probably due to paralytic ileus, it is a functional obstruction. A dynamic bowel occurs here, and due to the absence of normal peristaltic contraction, the patient presents with obstruction. Here, the pain tends to be less. There is absent bowel sounds. So this is in non-mechanical. In mechanical, what happens is there is dynamic obstruction, which is further being classified depending upon the speed of onset, whether it is acute, chronic, acute on chronic, and depending upon the site, is it small bowel or large bowel, depending upon the nature, is it simple, closed loop, or strangulated, and depending upon the cause, whether it is intrinsic, extrinsic, or intraluminal. Okay, so you just have to understand there is 2 types of classification, non-mechanical and mechanical. In non-mechanical, it can be due to paralytic ileus, and mechanical, it depends on the site, onset of the symptoms presentation, the nature, and the cause leading to intestinal obstruction. In dynamic obstruction, when we see things in detail, the bowel is capable of contracting normally or even excessively proximal to the obstruction. That is what happens in dynamic obstruction. It can be simple. Simple means there is obstruction at one particular point and there is no vascular compromise happening here. Okay. There is, in simple means, there is only obstruction at one particular point and there is no vascular compromise. In closed loop means there is obstruction at 2 points, forming a loop. That loop is being formed and it is grossly distended. The bowel gets grossly distended. In closed loop, there is obstruction at 2 points and the bowel loop gets grossly distended. In strangulated means here what happens, there is blood supply is compromised. There is no blood supply. The patient will have severe, sharp and more localized pain. The patient presents with severe, sharp pain. There can be peritonism. The patient can present with fever, increased WBC count. There can be signs of mesenteric ischemia. Okay, so in all these things, the presentation varies. That's why we have to understand. Sometimes you see the patient at home care, and from that visit, when you're seeing the patient itself, you should be able to pick out what it could be. Okay, so in dynamic obstruction, it can be simple, closed loop, or strangulated. In simple, there is only obstruction at one point. In closed loop, at loop is complete. There is obstruction at 2 points, and the risk of perforation is so much in case of closed loop. In strangulated, the blood supply totally is cut down, and there can be sharp pain. There can be associated with fever, increased WBC count, and other signs of mesenteric ischemia can be present here. Now, what is the cause? Why is this obstruction happening? So, when we see the causes, again, it gets divided into dynamic and adynamic causes. In dynamic, the cause can be intraluminal. Something inside the intestine is causing this obstruction. That is why the patient is presenting with intestinal obstruction. Intraluminal, the causes can be anything impacted. Even it can be a fecal mass that is impacted and leading to intestinal obstruction. It can be foreign bodies. Bizarre. Bizarre means the person who is having the habit of eating hair, due to some psychiatric illness. They constantly have this desire to pluck out their hair and, swallow it. And finally, what happens in the intestine, it forms a hair ball, and that can cause obstruction inside the lumen. Okay, that is called bizarres. Even it can be gallstones, which is leading to obstruction and be a cause for intraluminal factors. Intramural, something related to the muscle of the intestine. It can be due to strictures or any malignancy which is leading to obstruction. Extramural, outside the intestine, something like bands or adhesions, hernias, volvulus or intussusception can be a cause leading to mechanical obstruction. In adynamic cause, it can be due to paralytic ileus, mesenteric vascular occlusion or pseudo obstructions. Something not particularly related to the intestine, but it can be due to some, why paralytic ileus? Maybe probably due to hypomagnesemia or hypokalemia. It can lead to some, the forward movement, that prokinetic movement is being stopped, and that leads to intestinal obstruction. So in mechanical obstruction, causes can be adynamic or dynamic obstruction. In dynamic, it can be due to intraluminal, something inside the lumen is getting obstructed. Or intramural, the muscle wall is something causing some obstruction. It is having some problems. It can be due to some tumor growth or some strictures which has found leading to obstruction. It can be due to extramural factors like bands or adhesions, probably after any previous surgery or probably after chemo or radiation therapy, some stricture has developed, or a hernia, volvulus or intussusception leading to the obstruction. Now, can anyone tell me what are the common symptoms that patient presents with intestinal obstruction? Very common symptom, what a patient can present with intestinal obstruction. Vomiting, okay. Abdominal pain, okay. What type of vomiting do you see in intestinal obstruction? Abdomen will be tender, pain abdomen, hiccups, vomiting. Yeah, can you be more specific? What type of, vomiting, can you see? Green color. Okay. Anything else? What does that green color indicate? Anything in particular? Come on, sisters, you don't have to be shy. I'm sure you might have seen all these things. What is a typical history what the patient will say you? Yeah, green color, it could be due to stool. Bile can be a content in the vomitus, yes. Very commonly, the patient can present with high volume vomitus. What does that mean? High volume. The patient will give you a typical history. See, they'll come and say they are vomiting large amount of vomitus. They'll say in bucket they are collecting the vomitus. That much volume of vomiting it is being happening. Have you heard like that? Projectile vomiting. Yes. Yeah. So typically the patient can present with pain, high or large volume vomitus. The vomitus can be bile stained or sometimes even the fecal matter can be present in the vomitus. Very typical. Yes. So the common symptom that you see here is partial or complete in both in partial and complete bowel obstruction. The patient can present with colicky pain. That is a typical presentation. On and off type of pain can be there initially. Later it can be a continuous type of pain. The cause for colicky pain is the bowel contraction occurs to pass the obstacle. See, there is obstruction here. The intestine is trying to push it forward, and that time the pain occurs. That is a cause for pain in intestinal obstruction. Okay. You can also see that the patient's abdomen is distended. You can see the distension. Why? Because there is obstruction. The bowel is trying to push it, and there is increase in bowel contents, and it leads to increased epithelial the surface area increases and the bowel starts secreting lot of water and electrolytes, and that is why this so much amount of vomiting is also happening. The patient is saying I'm not even able to drink a little bit of water, but still I'm vomiting so much of water. So where is this water coming from? It is from the intestine. Intestine is secreting all this water and electrolytes out, and the patient is vomiting so much of water, and this is the reason why the patient is presenting with nausea and vomiting. And I said you, initially it can start as a colicky pain, later it can continue as a continuous pain. Why it occurs? Because the cause of the inflammatory response. The bowel is being affected and the bowel is started to distend and started secreting so much of water and electrolytes. And slowly what happens? The intestine is getting some inflammatory response is happening in the intestine, leading to continuous pain. And also then later what happens? Decreased movement in intestinal content occurs and leading to bowel obstruction. Understood. Bowel obstruction can be partial or complete. What is partial bowel obstruction? The typical presentation, what the patient says is he is able to pass some amount of stool. There is vomiting, there is pain. And when you auscultate, what can you hear? Some amount of bowel sounds can be heard. That is partial obstruction. And in partial obstruction, usually, or the small bowel obstruction, what happens is there is a large volume of vomitus coming out. Okay. Whereas in complete bowel obstruction, the typical presentation is there is no fecal matter he is not able to pass stool or flatus. And the quantity of vomitus that is coming out is also very less in complete obstruction. And once the vomiting starts, like some of you said, it can even be fecal matter that is coming out. Okay, so you should know how the patient is presenting to you with partial and complete obstruction. Why this is important? Because you will be seeing the patient at a home care facility. You're going to their home and then you're seeing, okay, the patient is now having so and so symptoms. You should be, maybe you are the first person who is seeing this patient in this particular condition. Okay, and then you will be the person who is informing the doctor. See, the patient is presenting with so and so symptoms. I think it can be a partial bowel obstruction. You can take the opinion of the doctor. So it is very important that you sisters should know what are the typical symptoms that a patient with intestinal obstruction will present with. Understood. So what are the symptoms? Can anyone volunteer and say same things that we said just now? I want you to unmute and speak. Okay, now I'll call out names. Sister Harini, Sister Binisha, Sister Lizzie, can you? Yeah.
Ma'am, it could be colicky pain,
Yes.
and as you said, as partial or complete bowel obstruction. Due to this colicky pain, he might be getting excessive vomiting
Yes.
and not able to.
Yeah. Along with vomiting, what else can you see, ma'am? What are the features that you see in partial obstruction? There can be
He is able to pass partially, means if he passes partial stool,
Yes.
uh,
Yes, he'll be able to pass some amount of fecal matter or even flatus that is there. And when you auscultate, you'll get
he
bowel
has a
sounds.
bowl sound.
This is very important because you should be able to identify because the treatment varies for partial obstruction and complete obstruction.
And
Why we are
complete
focusing on the symptoms? Because the treatment is different for both these things. Understood? So for partial obstruction, there will be colicky type of pain. You can have high volume vomitus. You'll be passing some amount of fecal matter and flatus, and you'll get bowel sounds also when you're auscultating. In complete obstruction, he won't be passing any stool at all, or maybe the patient will have very continuous type of pain. The vomiters can be, the amount can be less. Even that is possible. Understood. So,
Yes, ma'am.
yeah, so it is very important that you all should be knowing the features, the differentiating features between partial obstruction and complete obstruction. Okay. So, as I said earlier, depending upon the level of obstruction, the symptoms also varies. The higher the obstruction is, the vomiting develops early and in large volume. If there is a small bowel obstruction, the patient presents with large amount of vomiters. The vomiting quantity will be so much. The patient will give you a typical history that he is vomiting in buckets. That much of vomiters is being there, and it starts early. In large bowel obstruction, it is progressive. Abdominal distension is more. In large bowel obstruction, the symptoms develop slowly, and the abdominal distension will be so much in large bowel obstruction. In complete obstruction, what you can see, the patient will not be passing any flatus or feces. Even sometimes the patient can present with spurious diarrhea. What is spurious diarrhea? What does that indicate? I'm sure in the last class you might have heard about it. Yes, Sister Bindu. Ayo, what happened? No sisters are responding. Watery stools. What is a typical presentation of spurious diarrhea? What does that indicate? Sister Priyanka. Okay, I should start calling each and everyone's name now. Only water passage. No stools. Sister Priyanka, I want you to unmute and speak. What is spurious diarrhea? Spurious diarrhea is very common. Why? Because the patient or the caregiver will be saying you, see doctor, the patient is continuously passing stools.
Hello.
Yes, Priyanka.
Yes,
sister.
ma'am. That is water stool.
Okay. What does that indicate? Why is the patient having watery stools?
Doctor, the hard material it will not pass through the bowl, so the water only come out.
Okay. Okay. Here, what happens is after a period of constipation, that is very important. Whenever the patient comes and says, see, I'm passing continuously stools, please do something to stop it. This is a typical thing that you will hear from the patient or the caregiver. So then what you have to ask them is, was there a period of constipation following which you are having this watery stools? This is important. Because of the constipation prior, there might have been some fecal matter stagnant there or some fecalith already formed there, and the freshly formed stool is being seeping down through the sides of this fecalith, and that is what the patient is being presenting as loose stools. So what is the management in spurious diarrhea? Now you have identified, okay, the patient is presenting with loose stools, but actually the problem is constipation here. And how do you manage spurious diarrhea? Yes, Sister Bilkish. Depending on obstruction, we may give enema. Yes. I'm just asking, how do you manage spurious diarrhea? You give enema. Does that enema have any particular name or any difference in the usual pattern? Have you heard of higher
And is it
enema?
manual removal, ma'am?
Yeah, you can do a rectal examination and give do a digital evacuation. And after that, you give enema. Have you heard of higher enema? Where you insert a suction catheter and give the enema?
Yes, ma'am. We
Yeah.
do.
So in spurious diarrhea, when there is something like fecal matter higher up, maybe you do your rectal examination, you won't be able to remove that fecal matter. So what you do is you put a suction catheter and then give the enema higher up level above the obstruction. Only then the whole thing will come out. Sometimes you may have to repeat this higher enema maybe in the subsequent days also for having the full fecal matter to come out. So this thing is very important. So in complete obstruction, the patient can present with spurious diarrhea. Doesn't mean the patient is passing some amount of stool. Whenever you see or you have a doubt that the patient is presenting with intestinal obstruction, please do a rectal examination and see what type of rectal finding you are getting. Depending upon that, you have to manage. Understood. So when you're going for a home care, when you see the patient at their facility, make sure you go through the symptoms very clearly to have a clear-cut idea about what is the patient presenting with, whether it is a partial obstruction, whether it is a complete obstruction, or which level. Is it a small bowel obstruction? Is it a large bowel obstruction? Where is the obstruction happening? If it is a complete obstruction, what medicines you can give, what not to give. This clarity should be there. Why we are focusing so much on this thing? Because in complete obstruction, the management is different. Partial obstruction, the management is different. In order to go with the management, you may have to do certain investigations. What are the investigations that you know of in diagnosing obstruction, intestinal obstruction? Do we do any investigation here? Is it required to do any investigation here? Sometimes the caregiver is coming and asking you, Sister G, should we do anything? USG, not for these patients. Okay. X-ray, yeah. In X-ray, what is the typical finding that you see to say that this patient is having intestinal obstruction? Total count X-ray, yes. What are the finding that you see in X-ray? Air shadow. Where do you see the air shadow? Have you heard of seeing multiple air fluid levels? That is a typical finding that you see in an X-ray. You can see the dilated, distended loops along with multiple air fluid levels. If there is some perforation, you can see the air under the diaphragm. Understood. Only if there is perforation, you can see the air shadow, or the air under the diaphragm is seen when there is perforation. When the intestinal obstruction is severe, and then if it gets ruptured, you can definitely see air under the diaphragm. Okay. So here you can see the X-ray. You can see the multiple air fluid levels and the distended intestinal loops. So imaging like X-rays can be done. Contrast radiography can also be done. But if you're seeing the patient in a home care setting, the patient's condition is very poor. He cannot be shifted to a higher center for doing any kind of investigation also. You should be able to make out what the patient is currently presenting to us from the history. Understood. So this is another X-ray where you can see the distended bowel loops. Okay. Now you know the symptoms, what the patient is presenting with, how the patient is presenting with intestinal obstruction. And now you know from the history where the obstruction is. Now, what is your management going to be like? What are the medications that you have seen for given to such patients? I'm sure in the last class also you might have gone through few. You can unmute and speak or give your answers in chat box. NPO, okay. What medications will you give them? Antacids, okay. What else? ORS. What else? The patient is having severe pain. For pain, will you give anything?
You can give paraffin.
Parenteral, what?
No, sorry. Um,
For vomiting, what will you give?
Perinom TDS.
Perinom, okay. What is perinom? On what category does perinom come in?
Only
Perinom is a prokinetic agent. Prokinetic means it helps in forward movement of the intestine. Okay, so perinom can be given in case of partial bowel obstruction, but not in complete bowel obstruction. That is why I said you should be very clear with the symptoms. What happens when you give perinom in complete obstruction? Already the intestine is completely blocked and you're giving perinom. The patient will have severe pain. Worsening of symptoms can occur. Understood. So you should know what the patient is presenting now. If it is partial bowel obstruction, maybe it can relieve that stress and help in reducing the partial bowel obstruction. The patient is having complete bowel obstruction. You're not supposed to give perinom or metoclopramide. Understood. Yeah, perinom can be given in partial obstruction. That's true. In such cases, what else can you give? Any other antiemetic that you can give? What other
Condem
antiemetic?
can be given.
Ondansetron, yes, emisset. Emisset can be given. There is high volume vomitus. To reduce the secretions, can you try giving something? Have you heard of hyoscine butyl bromide? Your Buscopan?
Yes.
Yeah. So Buscopan is a very good drug. It helps in decreasing the secretions as well as the pain. Okay. So Buscopan can be tried in such situations. If have you heard of octreotide? Octreotide also helps in decreasing the secretions. But the problem is octreotide has it is a bit expensive compared to hyoscine butyl bromide. Hyoscine butyl bromide or Buscopan is cheaper and does the same thing as octreotide. Both helps in decreasing the secretions. So in your medication, you can try your antiemetics. Before helping decrease the secretions, you can try giving hyoscine butyl bromide. And then for the pain, what can you give? You can try opioids if needed. Here again, there is two school of thoughts, which is opioids sometimes can lead to constipation and worsen obstruction. But in such situations, what we think we focus is on to reduce the pain. Obstruction and this constipation we can manage other ways also, but we want the patient to be pain free. So we can try opioids. It can be tramadol if the patient is able to take orally. Maybe we can try tramadol as orally or intravenously if required. Most often, what we do is we may have to start the patient on continuous, morphine or fentanyl infusions if required. Okay. Have anyone given steroids for intestinal obstruction? Have you seen steroids given for intestinal obstruction? Steroids are also very useful in treating intestinal obstruction. Most commonly, the steroid that we use is dexamethasone. Why dexamethasone? Because it is long acting. It is given as a single shot in the morning and it is long acting so that the patient will have better symptom relief. What happens if you give dexamethasone later in the day, like in the afternoon or in the evening? It disturbs with the sleep. So we prefer to give dexamethasone in the morning time, preferably before 3 o'clock, and then give the complete dose. Okay. Only problem is sometimes it can elevate the blood sugar levels, but you can manage that with your insulin or OHAs, whatever it is. Okay. So this is the medical management. What we said till now was medical management. Do we have surgical management for intestinal obstruction? Yes, we do have surgical management also. If it is a single point obstruction, I said you there is single point obstruction or a closed loop obstruction or a strangulated one. If it is a single point, maybe you can try resecting that and connecting and go ahead with the surgical management. If there is multiple level of obstruction, there is no point in doing a surgical correction. Okay, so we should be very clear about what the patient is presenting with, what intervention and management you're going to do for a patient. It varies from patient to patient. Okay. Now, this is a flow chart which will help you in deciding what is the management that you're going to give to your patient. So the patient is presenting with symptoms of malignant bowel obstruction. I said we can do investigations if that is possible, like X-ray or ultrasound or whatever it is, you can do your investigation. Clinical assessment is the first thing. Very important thing that you have to take care is the clinical assessment. I understand if it is a small bowel obstruction or a large bowel obstruction. Is it a partial obstruction or a complete obstruction? And then there are certain factors which will help you in making or taking a decision in malignant bowel obstruction. So there are patient factors and disease factors and technical factors. In patient factors, there is age, performance status, the stage of cancer, future anti-cancer treatment options, if there is malnutrition, cachexia, or concurrent illnesses. So these are patient factors, whether the patient will be able to undergo a surgery or not. From the patient's performance status, we may able to say, okay, whether we have to move ahead with surgical management or just the medical management, what is required. Okay, even though there is age is given the first one in the list, performance status is what you should be actually looking into. Even the patient, it can be in his 60s, late 60s also, but he's a very active person who is able to, if you think the patient will withstand a surgery, maybe you only then you can go ahead with surgery. Otherwise, medical management is the best option that you can give to the patient and family. Okay, so the patient factors, again, you have to remember the performance status, the age, the stage of cancer, future anti-cancer treatment that you're going to do. See, after resection, maybe you may have to give some radiation or chemotherapy. Will he be able to tolerate all these things? From the patient, when you see the patient, you should be able to make out. See, whenever the patient is presenting with a intestinal bowel obstruction, it is the team that has to decide what to do next. So that is why after doctors, maybe you are the ones who are given the priority. Maybe you can say your doctor, see, I don't think the patient, if suppose the doctor is saying, okay, we can go ahead with the surgical management, but you are the ones maybe talking to the patient and families in great depth. They may have a good rapport with you, sisters. So what will you do or convey to the doctor? See, doctor, sometimes I don't think the patient can afford this. That is one thing. And also his future or the family who's surrounded by them, I don't think they'll be able to take care of him in a particular way, which is supposed to be like that. So these kind of decision making, it is from the team that is happening. So maybe you are the ones who's going to help your doctor and say, see, doctor, maybe you need to change the planning, what we are going to do ahead for this patient regarding the surgery. Maybe we need to rethink it. Understood. So this kind of factors are very important in decision making. So we've discussed about patient factors. Now there is disease factors. Depending upon the stage of the disease, the extent of obstruction, whether it is single level obstruction or multiple level of obstruction, depending upon the site, that is it proximal or distal, where the obstruction is, and the etiology, what is causing the intestinal obstruction, is it functional or mechanical? Mechanical, we discussed in the starting itself, if there is any tumor mass, or is it intramural factors or intraluminal factors that is causing this obstruction. If there is ascites or carcinomatosis peritoneum. Carcinomatosis peritoneum is widespread metastasis inside the abdominal cavity. If such a situation you are seeing the intestinal obstruction patient, there is no point in going ahead with the surgical management. Okay. Then technical factors, the degree of invasiveness, how much the disease has progressed, if any interventional radiology is possible, endoscopy, laparoscopy, or any anesthetic requirements. All these are technical factors. So whenever a patient presents with intestinal obstruction in front of you, you must have a very clear clinical assessment. If possible, go ahead with investigations. Even without that also, you can go ahead with the management. It's not necessary that you are saying you only if you take a X-ray, we can manage you. No, you can't say that. With the clinical assessment, you will definitely get a clear idea what the patient is presenting. Understood. And then comes the management. Now you have a clear history. Now you're going to manage. You're going to take a decision. Is it medical management that you're going to take or surgical management that you're going to take? If it is medical management only, then the patient will have particular criteria. Okay, if the patient is not able to withstand all these things, only medically we can manage. The disease is progressing. He's maybe in a deteriorating stage. There is no point in taking him for a surgical management. Or suppose the patient is very young, he's able to withstand all this kind of surgery and all those things, maybe we can go ahead with the surgical management. So this flow chart should be there in your mind whenever you see a patient when it comes to their management. So this is just a summary of what we said. Whenever the patient is having advanced age with cachexia. What is cachexia? The patient will be very thin and lean. He will be malnourished because of the cancer. So when the patient is in such a situation, that is a complete no for surgery. If the patient is having widespread tumor, deranged metabolic parameters, the patient is presenting with ascites, or low serum albumin, then also there is it is a complete no for surgical management. The patient is having severe nutritional deficiency, there is palpable abdominal mass, or previous radiotherapy to the abdomen or pelvis, there will be probably adhesions present. So such conditions also we don't prefer doing any surgical correction in such patients. History of any combination chemotherapy, multiple sites of obstruction, poor peristalsis due to diffuse carcinomatosis peritoni, poor performance status, then definitely all this category patients who are coming to us, it is a complete no for surgical management. I think Sister Bilkish has raised their hand. Yes, sister, you can unmute and speak. Okay, any doubts so far? Is everyone sleeping? Nobody is responding. Okay, network problem. Okay, Sister Ji. Okay, so let's move forward. Now, coming to the treatment, I said pharmacological treatment, you can try laxatives. If it is partial bowel obstruction, definitely you can try laxatives. Commonly used laxatives like stimulant laxatives, stool softeners can be tried. Even enema, if enema can be tried in case of partial bowel obstruction. And we'll see how the patient is responding and adjust the dose accordingly. I said corticosteroids are also very useful in treating intestinal obstruction. Steroids are used in many conditions, especially in palliative care, very useful drug. Most commonly used is dexamethasone in a higher level. We have to give it in a higher level in case of these conditions. Antiemetics, I said metoclopramide or ioperidone can be given only in case of partial bowel obstruction. It should not be given in complete obstruction. So that you have to keep in mind. Anticholinergics, these are medications that help in decreasing the secretions. Okay. And somatostatin analogs like octreotides help in decreasing the secretions, thereby reducing the volume of vomitus. Then analgesics, definitely for pain you have to give opioids or as required, whatever it is, you have to continue the pain medicines. Surgical management, I said the resection of the bowel segment can be done where that obstruction is there. Colectomy, ileostomy or colostomy can be done. Invasive procedures, you can put nasogastric tube insertion can be done for decompressing. I said there is distended bowel. To decompress that, you can put a Ryle's tube and decompress the abdomen. Gastrectomy or colonic stenting can be attempted. Now we'll see each drug in detail. Antiemetic, I said metoclopramide, it is a dopamine antagonist with a starting dose of 10 milligrams as 8 hourly. You can gradually increase the dose day by day basis. Higher dose is maximum 30 to 120 milligrams over 24 hours. It can be given via subcutaneous, it can be given as subcutaneous infusions also. So this medicine, and it's a prokinetic, and it should be given only in partial obstruction. Okay. Haloperidol for it can be given for nausea and vomiting. If it is not being controlled with your regular antiemetic, you need to combine it with haloperidol. Haloperidol, what the dose is 2.5 to 20 milligrams over 24 hours. It can also be given as subcutaneous infusion. When the patient is continuously vomiting, dehydrated, you may not get a IV line. So you can give it as subcutaneous infusion also. It has similar action. Next, medication is your steroids. Most commonly used is dexamethasone. 16 milligrams per day is the usual dose that we give. Here again, you can give it as IV and sub-Q as well. It is long acting, so it is given usually before 3 p.m. A later administration can interfere with the patient's sleep. So it is preferred to give as a morning dose. But we commonly in general practice used to see dexamethasone given as TDS doses or BD doses. But whenever you ask the patient, he'll give you a typical history that he couldn't sleep. So if you're planning to give steroids, give it as a single shot in the morning. It's not just for intestinal obstruction. Whenever you give steroids, especially even for asthmatic patients, some people or breathlessness problem, you give start them on steroids. If you give at a night dose of steroid, the patient will have difficulty in sleeping. So always prefer to give it as a morning dose. Okay, and also the patient with on steroids can have gastritis. That is another complaint that you hear. So give a antacid along with that, or your PPIs, pantoprazole or something like that. You have to give along with steroids. Usually it is given for a period of 5 days and taper it as required. If vomiting subsides, change the IV or subcutaneous route into oral steroids. Steroids act by reducing peritumoral edema. This is very important. How steroids reduce the vomiting? It decreases the tumor edema, thereby it creates some space so that that bowel obstruction is relieved. And that's how it helps in reducing the vomiting. Understood. And always make sure if the patient is on steroids, you monitor their blood sugar levels because steroids have that tendency to raise the blood sugar level. So monitor that and manage the blood sugar levels accordingly. Next thing is stomatostatin analogs. I said you octreotide, very commonly used, 100 to 600 micrograms per day is the dose. It will reduce the secretion, slow down the motility, reduces the splanchnic flow. It increases the absorption of water and electrolytes. It is a potent anti-vasoactive intestinal peptide effect. It has a potent anti-vasoactive intestinal peptide effect. Also try to prevent as a preventive step. If you're seeing the patient in a partial obstruction stage, you start it then and there so that you can prevent the happening of a complete obstruction. Okay, depot preparations like 20 milligrams for 4 weeks or 4 weeks is also available along with it can be combined along with steroids. You can start somatostatin analogs. Only thing is it is a bit expensive. You can try using hyoscine butyl bromide instead, which is cheaper and also has the same effect. So this is how your prescription will look like. You'll have your steroids with a higher dose, 8 to 16 milligrams is what we have to start him on, either as subcutaneous or IV preparation of dexamethasone should be given for a period of 3 to 5 days and then slowly taper it down. And you will have to combine it with an antiemetic, either metoclopramide if it is in a partial bowel obstruction, or you can add your hyoscine butyl bromide to decrease the secretion as well as the vomiting. And haloperidol can be added to decrease the vomiting. Ranitidine, here again, it has anticholinergic property also. It is an antacid along with anticholinergic property. So it helps in decreasing the vomiting. So when the patient is continuously vomiting, and as some of you said, we have to keep the patient in NPO. We'll stop all oral fluids. So very common questions which the caregivers will come and ask you is, sister, how will I feed him? Or how won't he feel hungry? Even the patient themselves may ask you, like, sister, I'm hungry. I want to eat something. I'm really feeling hungry, but you have kept me in NPO. What will you say to them? Sometimes these patients are afraid to talk to the doctor directly. They'll be coming and asking you, see, sister, I'm hungry. I want to eat something. They have put this rice tube, but I'm feeling very hungry. What will you say to them? Ice cubes could be given. Okay. Can he drink water? Is it okay to drink water or take anything to orally? Start IV little amount. Give
Sips of
feeds.
water, ma'am, he can have, no?
Sips of water. Yes, yes. Sips of water can be given. If he's able to take orally, that is okay. Even if he's on a Riles tube, we can ask the patient to start. If he is able to take orally some amount of fluids, definitely you can ask him to take orally. Even some people they take oats, like very smashed and mixed in a grinder, that liquidy type. Even some people take that. If they are able to tolerate, okay, let them have it. This is a very difficult situation to manage. The patient will be continuously vomiting. The caregiver is upset. Since the patient is not eating anything, the caregiver is also not eating anything. So it's a very difficult situation to handle. And when the patient starts saying, see, I'm hungry, the caregiver is totally shattered. Especially in our Indian culture, feeding is given such a high priority. And when this situation happens, the family is totally shattered, uh, thinking that, oh my god, my husband is not eating, how will I eat? Even husband, he himself is saying he's hungry. If I don't feed him, they feel guilty. So it is a very difficult situation. We need to work here as a team. So if the patient, if he's able to take sips of fluid, encourage him in taking it. If he's able to, chew something but not able to swallow, then ask him to spit it out. We even have that situations. The patient feels like eating something, favorite food of theirs, they feel like eating, but when they swallow, they're having some difficulty. We ask them to chew and then spit it out. Even that, if that is possible, we can try that. Okay. And the feeds that you give through the Riles tube, sometimes for decompression we have put the Riles tube, and giving feeds through that is sometimes difficult. So we'll see. We'll have to figure out ways what is working for the patient. Okay. And so hydration, definitely we can try IV fluids. Sister Priyanka is saying little amount of semi-solid food we give, the response positive, and then we give proper amount. Yes, that is what I said. See, there is no clear-cut answer to that. The patient is only able to tolerate water, maybe only water we can give. The patient is able to take some amount of solids, even one small bolus of morsel of the rice, if he is able to take, okay, that is, if he's able to take that, okay, let him take that. There is no restriction, because in this end of life situation, if you are saying this strict restrictions, it is very difficult, okay, for the patient as well as a family. So whatever he is able to tolerate, let him take it. And some people, we may have to start on IV fluids. And this IV fluids is not a clear indication. It is just for the satisfaction of the family members and the patient sometimes. The patient may have edema all over the body. And if you give this IV fluids, it may sometimes worsen the situation. Okay, so see how your patient is responding to each and everything that you're doing. When you start your steroids, definitely some amount of the edema will come down. The patient may have some improvement in appetite also. The patient moods changes. So you need to give some time for the medicines to act, and then maybe keep NPO for few days, and then maybe start small amount of feeding. Okay, what is TPN? Have you heard of TPN?
Total parental nutrition.
Yes. Okay. This is very commonly given in gastro departments. You can see the patient in TPN with that milky fluid flowing. Previously, it was given via central line. Now, peripheral lines also you can give TPN. But the problem with TPN is it is very expensive, or it can be given in patients who is having a better prognosis. Maybe you need to extend some more time. Then we give TPN. But there is no clear cut indication for a patient who is in his end of life. It is not necessary that you need to go ahead with TPN. Yeah, through IV fluids or IV feed also we can give. Previously, it was given as only central line preparations. Now we have newer preparations through which the peripheries also you can give your TPN. Then nasogastric tube or gastrectomy, is it really required? The patient is having complete obstruction. The family feels that only through orally he is not able to take through the tube. Maybe you can give your feed. They'll have lots of queries. They'll come and ask you, keep on asking, can we do that? Can we don't? If we do this, is there any problem? So many questions will come, especially related to feeding. So I said you TPN, the total parenteral nutrition, it is justified in patients with minimal tumor burden, candidates for a definitive surgery, and in patients with good performance scale and a good life expectancy. Then maybe you can try TPN. Otherwise, for a patient in a deteriorating stage, there is no indication of starting a TPN. So I said you intestinal obstruction is a very difficult situation to manage. You need a team, fully focusing on the patient as well as the caregiver. They'll have lots of questions. They'll be going through a lot of emotional problems. Seeing their loved one in continuous pain and distress is not a good thing. So whatever decision you take is very valuable. That is you and your doctor, whoever is there in the team, your social officers. It's a very combined effort. The problem with intestinal obstruction is each and every patient will have a particular sets of presentation. Your management changes, the medicine that you give changes from person to person. Should be very careful in dealing with a patient with intestinal obstruction. Any questions?
Thank you, Sangeetha ma'am, for the wonderful presentation. Anybody have any questions?
Ma'am,
Yes,
over.
okay. Ma'am, please continue.
Okay, so we started the presentation with a small case scenario. We'll see the remaining case also. So I said there is our patient Mary. She's 62 years old and her children are living in UK. She was diagnosed with stage 4 gastric adenocarcinoma with metastasis to peritoneum and anterior abdominal wall. She had a palliative distal gastrectomy followed by chemotherapy. Unfortunately, a repeat CT showed that the disease is progressing. Now, what she presented was she had vomiting and abdominal colic for 2 days, and she was able to pass small amount of stool daily. Okay, she had vomiting 3 to 4 episodes per day, which was unrelated to meals. Vomitus was bilious with particularly digested food. On examination, she was not dehydrated. Her abdomen was distended, bowel sounds were sluggish. Palpable nodules was present on the abdominal wall, which was mildly tender. From the history, where do you think is the obstruction here?
Partial obstruction maybe.
Okay, why, sister, do you think it is partial obstruction? What are the features from which you identified it as partial obstruction?
Mild sluggish vowel sounds,
Okay,
mild distension,
okay,
it's not dehydrated,
okay.
partially vomitus with partially digested food.
Yes. So now you are an expert. Now you are able to identify the patient having bowel obstruction. Is it partial or complete without doing any investigation? Understood. So this is why and knowing the symptoms is very important. So in view of persistent vomiting, the nasogastric tube was inserted. Yeah, nasogastric tube was inserted. Mary was told that the nasogastric tube insertion is a temporary measure for decompression. CT was taken and it showed small bowel obstruction with the transition point at the proximal junction. As she was still opening her bowels, the impression was partial rather than complete obstruction. The intention of the management was to reverse the obstruction. Understood. So she had following days, she had a CT taken, and from that they could identify it was a partial obstruction. From the history itself, it is very clear she is having partial bowel obstruction. Understood. So all these features suggest that she's having partial bowel obstruction. Now, what is our management? We are trying to reverse the partial. Understood. We are trying to reverse her condition. So this was the treatment that was given to her. She was given bisacodyl suppository and regular intervals. She was given IV metoclopramide 10 milligrams 8 hourly and intravenous dexamethasone was given 8 milligrams. Do you have any opinion on this prescription? Do you think this prescription is correct or wrong? This was the management given to her. Yes, sister, what do you think? It's okay, no problem. Just say, is it okay to give this prescription medicine, or do you find this prescription has something wrong in it? Do you want to correct it? Yes, Sister Sindhu Mol. I think you want to say something.
Regular interval metoclopramide is
Do you think giving a suppository will help this patient?
no.
It's not
No.
going to help her. So this prescription is wrong. Huh? So there is no point in giving suppository for this patient. You have to do a rectal examination. Maybe she needs a high-up enema. And the dose of metoclopramide is not sufficient. As giving her a tedious dose of metoclopramide will not help her. And intravenous dose of 8 milligrams steroids is also not going to help her. I said you a higher dose of dexamethasone is required. At least a 60 milligrams of dexamethasone should be given. Only then she'll have some amount of pain relief. But this was a treatment given to her. Okay, she was also started in fentanyl infusion for the pain and probably due to the peritoneal metastasis, which was present for 2 months. For the pain, fentanyl infusion was given for, but the prescription here is wrong. I said you intestinal obstruction is a very common mismanaged thing. So it is very important to identify what is wrong in the current medication and change as per the patient's symptoms changes. Understood? So the patient was given that treatment initially. What here you saw now, this was a management given for her. And what happened? There is no bowel action. The IV metoclopramide was increased to 60 milligrams per day in the following day. After increasing the metoclopramide, there is marked clinical improvement in 2 days. NG aspirate has reduced significantly and she had no more vomiting. So when the dose of metoclopramide increased, vomiting decreased and the aspirate has decreased. So what the doctor and the team did, they removed the nasogastric tube and started her on oral feeds gradually. And intravenous metoclopramide and dexamethasone were continued for 2 more days and stopped subsequently. Then what happened? After 3 days, she started vomiting again. What do you think is the cause? I said you dexamethasone and metoclopramide should not be stopped suddenly. It should be given for continuously for some more days as IV or subcutaneous and later switch it to oral preparation and only then stop it. When you suddenly stop it, all the symptoms will come back again. And that's what happened here. 3 days later, she started vomiting again. She had continuous vomiting and it was moderate to large amount of bilious vomiting. She was recommended to start intravenous metoclopramide again and dexamethasone again, in addition to IV ranitidine to reduce the gut secretion. Despite all this treatment, Mary's symptoms still persisted. Why do you think it still persisted? Here again, the dose of dexamethasone is not being increased. See, this is a very commonly seen mistake. That is why I'm trying to put these mistakes in so that you'll be able to identify. The dose of dexamethasone should be again increased. and the IV metoclopramide 60 milligrams may not be sufficient. You may have to start her on a continuous infusion. These are the common mistakes that you see when you're treating the patient with intestinal obstruction. So again, even after you changed all these things, she still had symptoms. So the goal of care was established after discussing with the patient and her family. She preferred to keep the nasogastric tube for decompression while she enjoyed taking fluids orally. So this is what we said her. She is able to take fluids. Orally, she is able to take even though she is having the Riles tube. The goal of care was discussed only now. When do you think the discussion should have happened? When the patient was initially started on treatment itself, the palliative care, that's what we say. The palliative care should start at an earlier stage. It is not when the patient is presenting to you with intestinal obstruction. Understood. When she had a distal gastrectomy, when she was diagnosed with the disease itself, the palliative care team should have been consulted and proper. See, when a patient is having an intestinal abdominal cancer, we know how the disease trajectory is going to be. There is chances that the patient can present with severe pain. The patient can present with intestinal obstruction. So all these things, we as a team should foresee and plan things accordingly. Understood. Here, this is when the patient is presenting with intestinal obstruction, only then you're going ahead and deciding the goal of care. The goal of care should have been discussed prior. And she preferred to keep the nasogastric tube and she's taking the oral feeds now. The decision was, finally, what was the decision? Was to stop her chemotherapy and go for comfort care. She only wanted medical management. I said you, her children are all well settled in UK. She's having enough and more money. But still, it is not necessary that she's having money, you go ahead with surgical management. You should always take the patient's decision. You should respect the patient's decision. The patient just wants comfort care. She's not willing to go undergo any surgery or any other TPN or any other kind of things. She just wants comfortable. She needs to be pain free. So when with that when that decision was made, we went ahead with giving her comfort care and she returned to home with home hospice support. So this case study is pointing out so many mistakes which we are doing in our day-to-day practice, and I want you people to correct it. Okay, sometimes the doctor may write a wrong prescription. Maybe you are the ones who is seeing it and maybe say, see, doctor, do you think this is what we should be giving? Maybe I think we need to increase the dose and try. Oh, if suppose the doctor is giving only 2 days or 3 days of antiemetics, maybe you need to ask the doctor, maybe we can continue for a few more days and then switch it to oral medicine and then taper it down or stop it. So these kind of inputs should come from the team, and that is why, especially being a palliative care nurse, you are having a more responsibility to identify such situations, or maybe the patient and family will be coming and talking to you more. You guys will be having more rapport than a doctor. So when you see the particular symptom, you should be able to identify, okay, I think doctor, this patient is going for a partial bowel obstruction. I think we need to intervene at the earliest. What happens once the obstruction is complete? The chances for perforation is very high. The patient can go for septicemia and shock and die. And we don't want that to happen. If there is any preventable cause or something which we can do, we have to take that step early and intervene fast. Understood? This topic is very important. It is very difficult to manage a patient with intestinal obstruction. As a team, we'll have to make so many changes every day, to see how the patient is responding to each medicine that you're writing in your drug chart. So we have come to the end of this discussion, and now we are clearly knowing, we learned the classification for intestinal obstruction. Now we know what are the symptoms that the patient can present to you with intestinal obstruction. We know how to diagnose if it is a partial bowel obstruction or a complete bowel obstruction. We know how we can do the diagnosis. And also we know the management, whether to go ahead with medical management or surgical management, what management you should be doing, even that you have a clear idea. And the treatment from a palliative care perspective. This is also very important. Yeah. Please feel free to ask any doubts, because this is a very difficult topic. More than learning it, practicing it is even more difficult. That's what I feel. There will be a lot of doubts coming around when you start treating these patients. So feel free to ask any doubts or questions. If not now, later on in your practice, if you're seeing some patient presenting with intestinal obstruction, you have any queries, please do contact Shiva sister or anyone in our team, so that we can have a detailed discussion in future also. Okay, regarding this. Over to you, Shiva sister. Thank you so much.
Thank you, ma'am, for the excellent session. Anybody have any doubts on this? Please. Even if you have a minute question also, please ask it. I'm sure you have seen different kinds of patient like this. So, ma'am, one question is there. Madam, you explained it. Okay. So, I thought this question. Any question? No. So, Madam was took the session very clearly, but I would like to highlight few things. Not all, one or two important things, because Madam has shared two the types of obstruction, partial obstruction and the complete obstruction. So, if you are assess the patients, you have to do the proper assessment. Then you will get an idea. Sometimes you will be suspect a partial obstruction, but the patient will be the complete obstruction. But the symptoms will look like say, a partial obstruction. So that time, what we do is our doctor prescribe the management of partial obstruction like metoclopramide, dexamethasone, and all. So if there is the action also, Madam was said clearly, because the metoclopramide has a prokinetic action also. It will increase the bowel movements. So just imagine if a complete obstruction, if you give a prokinetic drug like a metoclopramide, so again the drug will increase the bowel movements. So it's our duty to, if you start a metoclopramide and dexamethasone for a partial obstruction patient, sometimes it might be have a complete obstruction, but from the patient history, we thought like, okay, it might be partial obstruction. So after you giving the metoclopramide injections, you have to go to the patient and ask them whether they have the pain, the colicky pain increase or not. So that kind of things from the nurse's side you have to, because we all know that the metoclopramide increase the bowel movements, and if there is a complete obstruction there, it will definitely increase the colicky pain. So definitely, if you have seen these kind of understand these kind of things, you have to report to the doctor immediately and stop the prokinetic drug like the metoclopramide. So that is the very important point you have to keep it in mind. And the action also, the metoclopramide action is prokinetic action, and the buscopan. So in complete obstruction, we give a buscopan, hyoscine butyl bromide, and dexamethasone. Here also, if you give both metoclopramide and the buscopan, what happens? The action will contribute, because buscopan will try to decrease the bowel movements, but the prokinetic drug like metoclopramide will increase the bowel movements. So the action will be contribute. So that is also important. So this is the points I want to tell you all, because we all nurses, we are the person to carry out the doctor's orders and reassess the patients, and you have to find, if you give some medications and you are the person to see the patients all the times, better you can just visit the patient again and after giving metoclopramide. again you have to do the proper assessment. I think, madam, do you want to add anything? Otherwise, we can move on to the
Yeah,
case presentation.
Yes, sister. Like you said, the assessment part, once you start a medicine, assessment is very important. Within few hours itself, you will know how the patient is responding. Sometimes what commonly happens is, it is for the sisters, it will be like the duty shift. After this 6 hours, maybe you change and the next person is coming. The next person might not know what drug was. Maybe you'll say what, okay, you have started on this medicine. It is important to specifically say, we watch for these kind of symptoms since the patient is already started on this medicine. So these are the symptoms which we are expecting. So when you, on your duty time, if something happens, inform the duty doctor immediately. That is also your responsibility, because the patient can present with worsening of symptoms in maybe in the night. The medicine was started in the morning or afternoon, and the patient is presenting that in the night time. So the night duty sister must be aware, okay, this thing is going to happen. Sometimes we are expecting this thing to happen. If something really happens like that, you have to inform it to the duty doctor and stop the medicine. Okay, you should know this first. Only then you can act. Because this is a kind of emergency situation or emotional thing, because all of a sudden the patient was sleeping. Now he's presenting with severe pain. He will get upset. The family member will get upset in the middle of the night. It will be a difficult situation to manage. So whenever the patient you think in the ward you are having an intestinal obstruction patient, make sure you know this patient very well. The symptoms, what is going to happen should be taken into consideration. Okay, thank you.
Okay, we can move on to the case presentation.
Sister Kunda Pandurang Tindiv, ma'am, over to you. Ma'am, can you please unmute from your end? Sister Kunda.
आता ते पेशंटचं दाखवलं नाही.
Ma'am, can you please unmute?
Case വായിക്കോ, how to do?
Sister Kunda Randeep. Ma'am, can you please unmute?
Hello.
Yes, you are audible, ma'am. Please go on.
Hello. Shit, हे काय ऐकायलाच होत नाही.
Yes, ma'am, we can hear you.
She is a gallbladder, CA gallbladder patient. Hello.
Yes, ma'am, we can hear you.
Right now she is in Tata Hospital since Saturday, but 2 years back she diagnosed CA gallbladder and operate. 6 chemo is over. 12 chemo is over and 12 chemo is remaining. Patient was feeling drowsy due to chemo. Sorry,
Please continue.
And patient is not eating properly, loss of appetite, weakness is there. She is now still she is since Saturday she is in Tata Hospital for the pain. This is
Any
an
slides from our end?
hello.
Hello, ma'am,
हाँ,
please continue reading.
Huh?
Screen page.
Kunda, can you able to see the slides?
Yes.
Yeah, okay, you can continue.
Financially distressed, anxiety, and worried about family. Tablet Tapal 1 BD, tablet Olanzapam 1 BD, tablet Domstal 1 BD, tablet Pan 40 mg OD before breakfast, syrup Cremapin 10 ml at night. Pain in stomach, nausea and vomiting, giddiness, drowsiness, weakness, loss of appetite, and constipation. 1 year and 1.5 months old CA gallbladder patient. She is under chemo in Tata Memorial Hospital. She has pain, nausea, vomiting, worried about family and finance and pain. Discuss one. Hygiene and environmental factor, lack of understanding about cancer, lack of appetite and sleepiness, family distress.
So, thank you, Sister Kunda, for the presentation. Anybody have any more clarification regarding this patient story? Please ask well. So, Kunda, you said the patient was admitted in Tata Hospital right now, right?
Yeah, right now since Saturday.
Okay. So, what about the condition right now? Did she get adequate pain relief or what medication is going on?
Right now, medicine चालू है. Same line of treatment is going on in Tata.
Or oral medications or injections?
Oral medication.
Oral medication only.
Yeah.
What medication for?
Actually she gone for chemo, but they never give chemo because of lots of pain and nausea, vomiting.
Okay. What did you give for her pain?
Ultrasafe.
Ultrasafe.
Ultrasafe and Crocin.
Okay. So did she get adequate pain relief with the Ultrasafe?
Yes.
Now pain free, right?
Yeah.
Huh?
After pain is relief, and after
Okay.
PET scan and USG, they've decided chemo. Next chemo is giving or not.
Okay. Okay. So so I would like to ask one more question. Did she know the diagnosis and prognosis, or what about her understanding about the disease?
She is unaware of the disease.
Okay.
Yeah.
So we would like to hear from the participants' side. So how will you move forward? So this is the patient is not knowing the diagnosis.
Yeah.
So what is the next step? Others, please respond. Sangeetha ma'am, over to you. Give your suggestions. Please, others respond. Give your suggestions. If you have seen this kind of patients, how will you manage?
Ma'am, since she is having bowel, means she's not passing stool and due to that there is a pressure and she is getting pain. So for that we can give her enema and relieve that pain. No?
Sister Ji, yes, definitely we can
Okay.
try that. But the first thing which we should give priority is managing her pain. With tapentadol
Pain, yes.
was the medicine in the discussion point, which was, I mean, in the management part, which was written, tapentadol was given to the patient as BD dose. I don't know if she's having any pain relief with that. Maybe the oral medicines are not helping her.
Not helping her, ma'am. So she's
Prefer-
being admitted at Tata Hospital. I
Yeah.
think they are giving her IV.
Yes, definitely IV preparation. We need to see how she's responding to morphine or any opioid that is being started, and we'll see the response and manage her pain first, and then we'll go ahead with symptom management. You know, like if she's constipated, maybe we can try giving laxatives. We'll see if it is helping her. We don't know if it is a partial obstruction or a complete obstruction, but with our management, when it goes ahead, with that we'll be able to identify what she's having. And also she's, as sister said, she's not aware about the diagnosis and prognosis. So in such situations, most probably the patient himself or herself will be knowing something is wrong with her. Very commonly, maybe it is not necessary that the family members have said it to the patient directly, but they will have an understanding, okay, something is wrong with me. They will have a lot of emotional factors leading to increase in pain. In
Yes,
pain, when
ma'am.
when we discussed about pain, these are some spiritual factors or emotional factors can add on in her pain. Maybe we need to have a detailed insight exploration with the patient and family separately, of course. We need to ask the family members why they are not ready to discuss all these kind of things with the patient. Of course, it can be out of love. We don't want the person to have to know the diagnosis and deteriorate. So let him know it themselves, or don't say it at this moment. These kind of problems are very common. So I said you, whenever the patient is diagnosed to have a particular condition, it is then and there you need to refer the patient to a palliative care setting, and you can track the disease trajectory and give the family an insight, prevent intestinal obstruction from happening. If it happens all of a sudden, there is no point in saying that, but still, if a general idea, especially constipation and all, can lead to intestinal obstruction if it is not intervened at a particular time. So make sure the patient is taking adequate amount of laxatives, especially if the patient is on opioids. The chances of constipation is so much. Can you just go back to the previous slide? Yeah, this in the medication chart you can see the patient is only given syrup cremafin. There is no stimulant laxatives. If you give a small dose of this stool softeners like cremafin, it is not going to help her with her constipation. Maybe that might have led to this patient developing intestinal obstruction in the first place. Even olanzapine to a milder dose, it causes constipation. You should
Okay.
actually this prescription is wrong. I said you, this is why one common thing very commonly seen whenever you write a medicine, we go through the prescription daily and change medicines if required. Whenever a patient is started on opioids, make sure there is a stimulant laxative and stool softener in that prescription. If not, what will happen? The patient will develop constipation, and eventually this constipation will lead to partial or complete bowel obstruction and leading to perforations. So these things can be prevented. So all of a sudden, if some tumor mass is exploding and causing perforation, okay, it is inevitable. But preventable causes should be prevented. Sometimes a doctor forgets to write it. You are seeing the prescription. You can take the prescription to the doctor and say, see, doctor, you haven't added a stimulant laxative in this group. Maybe you can add that. Then the doctor will write it. See, in a busy OPD, I said you, it is a teamwork that is happening there. So these things, you should see what are the prescriptions written. Recheck, question each and every medicine that is being written, why it is being written. Is it helping the patient? If not, what can be done? And now the patient is presenting with intestinal obstruction. So these things should be evaluated in each and every visit. Most commonly, maybe 2 weeks visits or a monthly visit. You see the prescription, you see what the patient is saying. The patient may say he's having constipation, but his usual pattern is he passes stool once in 3 days. If it is his regular pattern, it's okay. If not, the patient is on opioids, still he is not passing stools, then you have to rethink. If the patient is taking a stimulant laxative as a HS dose, OD dose at night, then maybe you need to increase the frequency. You can change it as a BD dose or maybe a TDS dose. along with crimafin. Crimafin 10 ml at night is not sufficient. Minimum 15 to 20 ml of crimafin or a stool softener should be given. 10 ml is not sufficient. Understood. If it is
Yes,
given as
ma'am.
HS dose, maybe you need to change it as BD dose. If BD dose is also not helping, you need to ask him to take it as TDS dose. If he is not passing stool more than 2 or 3 days, definitely he should be given a suppository, bisacodyl suppository, and see if he is passing stools. If not, ask the patient to come and see you and do a rectal examination and give a enema. We have patients who is coming to us with 10-day history of constipation, even a month history of constipation. These are all very risky, especially if the patient is having an intestinal tumor. So these things should be kept in mind. Whenever a patient is diagnosed to have a particular condition, especially a CA related to the intestine, you need to know the disease trajectory. Probably the patient can go for a intestinal obstruction. So the preventable causes, especially due to constipation, if he's going to develop intestinal obstruction, definitely it could have been prevented. You know, opioids are going to cause constipation. So already on a constipated person, you're adding your opioids for pain management. That is again leading to constipation. So these kind of preventable causes should be taken care of.
Okay, ma'am.
Okay.
Thank you, ma'am. Anybody need to add anything? Any points who wants to add? So madam has covered all the points. As ma'am said earlier, definitely if the patient is having physical problems, try to control their physical problems first and then look into the other aspects, because we need to look into the 4 aspects. Total care is given for in any patients. You have to look into the physical aspects and then you can move to the other aspects also. And another thing is, this patient is doesn't know the diagnosis because maybe because of pollution there. Sometimes the family will know the diagnosis. They will be hiding the truth from the patient. So because of their love, because maybe because of love, they will be worried about. They knows the diagnosis. They will be worried about a lot, and that kind of insights will be there in the relative side. So you have to listen their parts first and then make them understand well, and also you have to tell them also it is the right, the patient has to know the diagnosis. That also you have to tell the caregivers first, and then also you have to tell them what are the how you, if they are agree, so what all you have to tell the patients, not going directly and going to the patient and say directly you have a cancer, incurable cancer. So we all we all learn from the communication session. So you can use a spikes protocol for that, and definitely try to understand the patient's insight, and you have to convince the caregivers and just tell the patients about the diagnosis and all. You have to so that just imagine, so you will be in that place. You will not be able to know the diagnosis, that your caregiver, your relatives hiding the truth from you. So that all things you have just put yourself into that patient's side. So just think about that and talk to the patient and relatives and give a total care to the patient. Okay, thank you. So I think we can wind up today's session. Time up, Sangeetha ma'am. So it was a wonderful session.